Top Med Talk.
Well, hello and welcome to Top Med Talk. It's Desiree Chappell here in Prato, Italy for the 7th Collaborative Clinical Trials in Anaesthesiology. Now, this has been a great opportunity to hear from world leaders about all the most recent clinical trials. We've seen some updates, some ideas for what's coming down the pipe. But earlier in the week, we actually were at the ESAIC Euro Anaesthesia 2024, and I was able to catch up with our new co-host of Top Med Talk, Kate Leslie. Kate, thank you so much for chatting with me, kind of in a different scenario here, because you gave a presentation, Hot Topics in Anesthesia, at Euro Anaesthesia 2024, and I thought you could just give us a quick synopsis.
Well, it was a great honour to be asked to give that talk. They have they have an obstetric one, for example, as well at the meeting, and also a pain medicine one.
Yeah.
So my one was about anaesthesiology, and I was able to talk about whatever I liked. So that was great.
Yeah.
So before Christmas, I had a patient presenting for spinal surgery. He'd been cancelled a couple of times, and he came back, and when he arrived, he was in euglycemic diabetic ketoacidosis. And he was taking an SGLT2 inhibitor, and those drugs promote the renal excretion of glucose. And so it was a real stimulus to me to read up about that and learn more. And he was also taking semaglutide, which is a GLP-1 receptor agonist, widely used for weight loss as well as for diabetes. And both of these types of drugs have also been shown in large clinical trials to be good treatment for various types of heart disease and also kidney disease. So as you'll have observed in your practice in Kentucky, increasingly patients are showing up for surgery and they're chronically taking these medications for a variety of different indications.
Oh, yeah. We are seeing a ton of our patients on both of those. And our listeners may or may not know, but I'm also Vice President of Clinical Quality for North Star Anesthesia. And this is hot topics. I get emails almost daily on guidance. What should we do? What is our standard? We've put a couple different practice advisories out from a global perspective and some of the recent guidance from the American Society of Anaesthesiology and different organizations. Where do you feel like we stand right now after digging into the literature and seeing what's out there?
Well, there is no international consensus about how long we should hold these medications before surgery. So there's two different issues. The SGLT2 inhibitors have a rare complication of euglycemic diabetic ketoacidosis. Mm-hmm. And the GLP-1 receptor agonists delay gastric emptying. That's one of the ways they work. They also stimulate insulin secretion and suppress glucagon secretion. So with respect to the SGLT2 inhibitors, the incidence of diabetic euglycemic ketoacidosis is about 0.2%. With respect to the GLP-1 receptor agonists, aspiration of gastric contents associated with their use is extremely rare.
Yeah.
Probably less than 2 per 1,000, a lot less, in fact.
Mm-hmm.
So what we're trying to work out is what the impact of withholding these medications is on the risk of these rare complications, because both of these agents do not produce hypoglycemia. And therefore, there's no particular reason to hold them perioperatively for that reason. And also, if you keep them going, you get actually much better glycemic control than you would if you held them and then replaced them with insulin regimes.
Yeah.
And furthermore, there's harms associated with insulin regimes that you would see in your job as a quality director. Hypoglycemia, drug errors, increased expense, and possibly most importantly, patient confusion and distress about the need to give injectable agents.
Yeah.
So my opinion, having read the literature, is that the literature is inadequate. It's mainly case reports and retrospective cohort studies. It seems to me that there is probably a benefit to administering SGLT2 inhibitors until the day before surgery, and that's the recommendation of CPOC, which is the UK group.
Mm-hmm.
With respect to GLP-1 inhibitors, The American Society of Anaesthetists advised that oral agents should be held for 1 day and that injectable agents should be held for 1 week. I believe that this has caused some problems in the United States with deferral and cancellation of procedures, in particular gastrointestinal endoscopy. And there's a big backlog of cancer surveillance work that gastroenterologists and colorectal surgeons and so forth are concerned is being deferred for this reason. So there's a lot of international examination about what to do. My personal opinion on that front is that we should continue to administer those agents and that anaesthesiologists have the skills to deal with the potential for aspiration.
Right. That's what we do.
Yeah, that's our job.
We mitigate that, when we can. So is it a recommendation that we intubate anybody through rapid sequence induction for anyone on GLP-1s that we feel are at risk?
So there's a feeling that we should go a little bit more nuanced than that. And it depends on a range of factors which are not supported by evidence but seem on the basis of opinion at the moment to be reasonable. One is to determine how long the person's been taking the agent. If it's more than 3 months, then the mechanistic research has shown that the incidence of retained gastric contents goes down after a couple of months on these treatments. The second is to ask the patients about their symptoms. So nausea, vomiting, a feeling of satiety or a full stomach. They're common complications or side effects of these agents. So if you have a patient who has held their agent for the prescribed time or not, you can ask them about their symptoms. And if they don't have any symptoms and they don't have any other risk factors for regurgitation and aspiration and they're having a suitable procedure, it may be that the risk-benefit favours a second-generation laryngeal mask, or, if possible, regional anaesthesia to avoid the need for endotracheal intubation.
Yeah. And then lastly, what about gastric POCUS? We hear a lot about that.
Totally. So there's some great information out there about how to do gastric point-of-care ultrasound, how to make a qualitative assessment of whether there are gastric contents retained and whether they're fluid or solid. And then there is more advanced practice of measuring the volume of the gastric contents. So we know that for sure. What we don't know is whether implementing a gastric POCUS program reduces the incidence of regurgitation or aspiration, or how indeed doing that will change practice.
Yeah.
So I guess you'd need to do a large randomized controlled trial, which is always my conclusion.
Exactly.
From any question. So if you're a keen young researcher out there, this is definitely an area where you can make a major impact.
Yeah, I think we're going to be seeing a lot of that. I know there are a lot of projects. I've been hearing a lot of work being done in this space, so sure we'll hear more. Just very quickly, speaking of large randomized controlled trials, Kate, you're a preeminent clinical trialist in the world. What are you working on right now? What's one of your big projects?
We are working on what we've called the SNAP study, which there are a few SNAP studies. Ours has a small a and 2 P's. That makes us better.
Yeah.
So we're randomizing high-risk patients to sugammadex or neostigmine for the reversal of neuromuscular blockade after abdominal and thoracic surgery, and we're measuring post-operative pulmonary complications. We are going great guns. We've recruited 151 patients in May, which is fantastic.
That's great.
And we're collaborating with researchers in the UK. John Silversides and his colleagues are doing Sinfonia, which has got a similar but slightly different orientation. And we are going to do a patient data meta-analysis at the end. And so we're going to combine the two studies, and we should be able to, confirm our own findings, but also explore some of the subgroups of people who may be particularly at risk.
Fantastic. Well, hopefully that's going to have an answer for us. And so we as clinicians on the front lines will know.
What we normally find is our trials generate more questions.
We've been hearing that a lot this week as well. Kate, thank you so much for sitting down and talking about hot topics in anesthesia. But mostly, thank you so much for joining us on Top Med Talk. It has been such a pleasure to work together and holding down the fort down at ANSCA for Top Med Talk Down Under. Incredible work. Thank you very much.
Thank you, Desiree.
All right. Cheers, everybody. Thanks for listening.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.